Hi, this is Christian Klung. I'm here with Molly Brady, and we're going to discuss with you briefly the changes in our reporting for high sensitivity troponins. Hi, Molly.
Hi, Christian. How are you?
Great, thanks.
Thanks for having me to help you educate everyone on this exciting and big change.
Yeah. So, one of the interesting things that's happening is that we're changing our high sensitivity troponin reports. Previously, we were reporting them on a per deciliter basis, and now we're reporting them on a per liter basis, which just basically changes all the numbers from fractions to whole numbers, basically. And so the new high sensitivity troponin is now going to be set, and we're using this differently than the previous troponin. That we're going to be using this with gender differences and calculated differences between one result and the other. And so this basically comes from a problem of that the high sensitivity troponin used by itself misses over 10% of acute heart attacks that are occurring within 2 hours. And so we've come up with a solution of a 2-2-2-2 strategy, which is essentially two troponins, 2 hours apart with two EKGs and two genders. And then adding to that the HERE pathway.
I think that's a really important point, Christian, is that, high sensitivity troponin is highly sensitive, but it missed in that group of patients who are early presenters, as you said, within 2 hours, the sensitivity decreases. So by adding in the HERE score to a value-driven pathway, you increase that sensitivity back, upwards of 99%.
Yeah, and it basically lets us look at what the history is, and we will categorize if the history is highly suspicious versus moderately suspicious. And if it's has a high suspiciousness, we assign that 2 points, and if it's moderately suspicious, we assign that 1 point. We look at the EKG similarly. If we see high risk changes, they get 2 points, and moderate risk changes, they get 1 point. And then age, you get 2 points for being 65 plus, and 1 point for being over 45. And then risk factors, if you have three or more risk factors, you get 2 points. And then if you have 1 to 2 risk factors, you get 1 point. And basically, you get 0 points if you're low risk in all of those categories. And we total the score. And if you have a four or more, you're going to get a cardiac consult and stress test considered for that patient. But even if you're low risk on the score and you have a positive troponin, well, we're still going to move forward with getting a cardiac consult and stress test consideration or risk stratification. And then this was kind of an interesting concept of looking at the change from one score to another, what we call the delta over 2 hours. And Molly, what can you tell us about that?
Yeah, so there's two ways of thinking about ischemia and with high sensitivity troponin. And I think what's important to go back to here is the 2 hour pathway. I think if some people are familiar with other high sensitivity pathways or other institutions, they might see that that's 1 hour, they might see it's 3 hours. But here, after our discussions with the lab manufacturer Siemens, they decided that 2 hours was really the time limit that we needed to see meaningful change and not miss any ischemia. So again, as Christian was saying, your troponin level can be abnormal as an absolute value, which is concerning, but you can also get this delta change. So what's important about that is that a rise or fall, a fall in the troponin level is actually as concerning as an increase. And the fall can sometimes even take longer to present. So which is important, again, to have that 2 hour pathway. And so again, in conjunction with the lab manufacturer, they've decided that a delta of 10 increase or decrease represents an abnormal value. And this is representing significant change. And if that delta over time, that change over 2 hours is greater than 20, that's actually a critical value and is highly suggestive of acute myocardial ischemia.
Awesome. And then if the patient's got a negative trope and low risk, then that's a patient that we can send home for further outpatient follow-up and or outpatient cardiac stress testing, depending upon the presentation and our underlying suspicion. So
Yes,
again, sorry, go ahead.
I was going to say there's that subset of patients that if you present with a HERE score of 0 to 3, you have ongoing chest pain, constant chest pain for more than 3 hours, and you have an undetectable troponin, you actually don't even need to do a serial troponin on those. Those people can be discharged home with outpatient follow-up.
Yeah. And so again, our solution here is to get two troponins 2 hours apart with two EKGs. It gives us an opportunity to look for EKG changes that are evolving over that time, as well as to look to see if our EKG risks are increasing, if we're seeing T-wave inversions, if we're seeing ST segment depressions, new bundle branch blocks. There's a number of EKG findings, and we'll go into those details in just a moment. But what's new to our facility is that we're also doing this by gender, and so this was recognizing that females that have heart attacks are underdiagnosed when they're having them, and the mass of a heart for a female is slightly less, and so therefore a slightly less limit is necessary for them, and it just happens to coincide with our test of the number 55. So if they're 55 nanograms per liter or higher, that's considered abnormal for females, and males are given a higher limit of 79. But we'll report these as critical for either gender when it's 120 or higher.
Yes, and so the reporting here at Palomar will be it will be flagged in Cerner as an abnormal if it is, as Christian said, female between 55 to 119 or male 79 to 119. Those are also the 99th percentile. And then if the troponin is greater than 120 here, it will be flagged as a critical value and lab will call. But I think the most important thing here is that this abnormal troponin level is actually considered positive, and that patient is ruling in for ischemia. It's consistent with a positive troponin from the standard troponin pathway. And so that's why with these, we're pushing everyone in this pathway to consult cards and discuss further studies, risk stratifications, including, cardiac stress, cardiac cath, et cetera.
Yeah. And again, these 2-hour changes are going to be critical if they're plus or minus 20, and it's going to be abnormal if it's plus or minus 10. And essentially, really what we're looking at here is trying to find patients with this type of disease that have an incomplete occlusion of their coronary arteries. Now, that incomplete occlusion could just be due to plaque that's there. And basically what happens is when you have plaque there, you can have a demand injury where you need more oxygen delivered to the heart, and there's just not enough space for the blood flow to come through. And therefore, the heart starts getting an injury from that. And that's how a myocardial injury can occur. That's different than a myocardial infarction. A myocardial infarction is where there's a complete occlusion of the vessel and there's been an arrest of blood flow to the heart. And so in that case, that can still occur in the situation if you can just look at this space right here and realize that this artery here starts to spasm and constrict, this area is going to get compressed. And so this is where we could see people having a spasm, and the spasm releases, and maybe their chest pain improves or even goes away. And then we look at their troponin results, and their troponin, if it's a short period of spasm, their troponin result may be detectable, but it may not be it may not be over the limit. And so when we check another troponin 2 hours later, if we can see that limit is increasing by 10 or more, and certainly by 20, we recognize that this type of event has occurred. And similarly, if this had occurred and it improved and the patient just happens to present later, we may be catching them where their troponins are 54 and then the repeat troponin is 23. And we know that that event occurred. So we're still trying to recognize when did an event like this occur, which is why it's plus or minus with the change in troponin. Because those events are what we're recognizing, and those are the patients that we want to get a cardiac consult and risk stratification under stress testing for. And similarly, this can occur not just from a fixed plaque and lesion like this, but because a sudden thrombus formed on a smaller plaque. And again, same sort of episode can occur of coronary artery spasm, and we're either catching this while the spasm has just occurred and they're trending upward, or we're catching it because they presented later and we're watching the trend come down. But abnormal trends, high or low, are indicative of this type of event occurring, and those are the patients that we really want to identify and intervene with.
I think that's a really important point and kind of brings up the specific case where, what if you have a troponin level that's detectable, but it's not considered abnormal? So say maybe it's, 30 for females, and 2 hours later, you see that, it went to 45. So even though it remains in that technically normal range of troponin, it has a delta change greater than 10, which is a significant change. And so we really need to make sure we pay attention to that subset of patients, which would be, probably getting that third troponin, considering consulting cards. So I think it's particularly important to pay attention to that delta, regardless of your absolute troponin value.
Yeah, and we talk with lab and we talk with the manufacturers about the fact that if you test somebody twice, you might get a slight difference between one value and the next value. So there's some expectation that you're not going to have the same exact number every time you test, but we do expect it to be within that range of 10. So less than 10 is considered normal, and there you have it. Lastly, this is the actual pathway that we're following in greater detail. So this kind of goes through and helps you better delineate, well, what do we consider to be a high risk presentation? And it's really important to recognize just off the front of this is that we're not applying this pathway to somebody that we think is having a heart attack right now, like right in front of us. If they have an ST elevation MI, well, we're not applying this pathway to them. And if they're sitting there sweating and profuse chest pain and discomfort, and they've got ischemic changes on the EKG and prior history coronary disease, those aren't the patients we're applying this to. We're applying this to the patient who's presenting to us with possible signs of acute coronary syndrome, not the definite signs of coronary syndrome. So these are patients with chest pain or complaints of shortness of breath or some nausea or weakness, left arm pain, radiating discomfort, kind of anginal equivalent type of patients that we're applying these pathways to. And so we consider it highly suspicious if the chest pain is typical, right? It's exertional chest pain, and it's presenting with symptoms that are short in duration and more like acute coronary syndrome. Somebody who's having pain radiating to either arm or both, and also patients who are developing chest pain and getting diaphoretic or having nausea. And if it's worse than similar previous angina they've experienced, those are, and as well as the response to nitrate, that's considered high risk. The moderately suspicious is a combination of low and high risk features. So they can just have some pleuritic pain, maybe a little radiation. It could be a sharp discomfort with some with nausea, and that'll be kind of the moderate risk group. And then the group that doesn't get any points is if they're just showing with pleuritic pain only, if it's only positional, if it's not associated with exertion. And the EKG changes are considered high risk are new bundle branch block, ST segment deviations, and patients who are having T-wave versions of multiple leads is considered a high risk change in EKG, and that's 2 points for that. And then you get an intermediate risk of 1 point for very slight ST depression that's less than 0.1 millivolt, or for 2 inversions that are greater than 0.1 millivolt. And then lastly, you have age. If you're over 65, you get 2 points on the risk score. If you're over 45, you get 1 point. And if you're less than 45, 0. And then risk factors, 1 to 2 risk factors. So if you're diabetic or have hypertension, have hyperlipidemia, you smoke tobacco, you have a strong family history of coronary disease, these are all significant risk factors. And so if you only have 1 or 2 of those factors, you get 1 point. But if you have 3 or more, then you get 2 points.
Right. And Christian, does BMI come into a risk factor for the heart score?
I don't recall. It should, though. I would think obesity should be considered a risk, but that may not necessarily be fair.
Right. And actually, I think now that I'm looking on MD Calc, a BMI greater than 30 is considered a risk factor.
Right. So here we have, once we calculate a HERE score, we're applying it to this 222 algorithm of ordering 2 troponins 2 hours apart. And after the first troponin, if the troponin is elevated, then we're going to consult cards and consider some form of risk stratification, whether that's going to be a cardiac stress test or a cardiac cath, or if it's something in between like a stress echo. Those are decisions that we'll make in consultation and support of the cardiologist. If, on the other hand, the initial troponin is within normal limits or undetectable, we're going to wait for the second troponin and now evaluate again. If we have an abnormal troponin, that result is going to result in a cards consult and risk stratification. And if instead that troponin is negative, meaning less than 10, and that repeat trope, especially if it remains less than 3, we're going to discharge home. And if it's less than 3 on both, there's no indication for immediate risk stratification, and the patient can just follow up with the primary care physician. I think there's a little wiggle room if there are detectable troponins, but still satisfying no abnormal change in terms of follow-up with their primary care or cardiologist for outpatient risk stratification for those patients might be the plan for them.
Right, because we know there is a subset of clinical conditions where people will have a detectable troponin, and in fact, one of the issues with high sensitivity troponin is that it is so sensitive that it's going to detect a troponin in 50% of healthy individuals. So that brings up an important point that we really need to be sending troponin levels on patients and those whom we want to rule out ACS. If we send it on every patient, we're going to get a lot of detectable levels that we then either have to do serial troponins on or figure out what to do with. And also, it's going to be elevated in a lot of clinical conditions. So your patients with chronic renal disease are going to have a detectable level. If they're in failure, cardiac or respiratory failure, pulmonary embolism, myocarditis, there's lots of different conditions. It really represents at any time, did they have some kind of myocardial, damage? And so it could be chronic, it could be acute. And that's where the delta comes in as well, as we're trending it. Is there any meaningful change?
Yeah. And that really all just comes down to the point of understanding why you sent the troponin. If you're sending the troponin on a patient because your pretest probability is high or moderate that they have acute infarction, then you're using that to make a determination, is there an acute heart attack occurring? But if you're sending the troponin because you are concerned about possible injury, a patient with heart failure who's presenting, or a patient with sepsis who's presenting, and you're using the troponin as a method of further determining what that patient's risk or prognosis is, because we know with a patient with a pulmonary embolism or with sepsis or with heart failure who has elevated troponins that their prognosis is far worse than the other patients with that same condition without an elevated troponin. But you're not measuring infarction in those patients, you're measuring injury. And so that branch point is so important to understand, are you looking for injury or are you looking for infarction? And so because it changes the lens you use to interpret the results. And
Right.
and and I don't know if I can, just stress that enough. Like, you got to know why you set the test so that you know how to interpret it. And then so the number in and of itself is interpretable based on what your pretest probability was. And then you can assign a post-test probability to what we're going to do next in terms of prognosis or treatments.
Right. And when you're thinking about the result that you have in front of you, it goes back to, an updated version of what truly is myocardial injury or infarction. It's not only an abnormal level or this rise or fall, but it's also a history consistent with injury or ischemia. It's accompanied by a possible abnormal EKG. So there are different aspects that go into evaluating the patient, and if you think that result is really consistent with ischemia.
Yeah. So going back to our algorithm here, if 2-hour troponin is abnormal, we're going to go to, so this delta is abnormal, we're going to go to Card's consult to discuss further studies and risk stratification with them. And if at any point a patient has a troponin over 120, that's considered a critical result, and we'll still have a consultation with Cards for those patients that are presenting that we think this is occurring with infarction. Um, and that's pretty much it. Molly, do you have anything else to add?
I was just going to say, just in that far right category, that HERE score greater than 4, we know we're just saying, you have a HERE score greater than 4, you're going straight to consult Cards. But of course, we're going to do that EKG and troponin and, listen to the story as well, and then determine best practice. Because as we all know, maybe some of these will get to go home. Maybe some of them will, have a stress test from the ER. So there's lots of different disposition pathways, but we're hoping that we find the best pathway for that patient with our cardiology consultants.
Yeah, right. That's a great reminder that, like, if you've got a HERE score of 4 or greater and you've got a trope of 120, it's frowned upon to be put on through a cardiac stress test in those
Yes.
situations. You're supposed to go to to cath lab and with that type of patient and not put them through a cardiac stress. All right. Well, awesome. Thank you, everybody, for your time and attention to this. If there's any questions, feel free to reach out to us, and we look forward to helping everybody go through this next change with the with our high sensitivity troponins. Thank you,
Thanks,
Mom, so
Christian.
much.
Thank you.